a simultaneous translator as well.
Apparently everybody understands.
Everybody understands English?
Yes.
Yeah. Very good. Okay. Well, thank you for inviting me. And I will try to tell you something about new treatment options in Alport syndrome. The basics about Alport syndrome you just heard in the previous talk. Alport syndrome is due to genetic variants in these genes, COL4A3, COL4A4, and COL4A5, and they encode the chains that are woven together into a very tight fabric, which we call collagen type 4. And you can imagine that if there is a mistake in the information, in the genetic information for these chains, so that they're not made properly, then this fabric will not be as tough, as strong, and as durable as it should be. And so it will break down more easily, it will fray more easily, and when that happens, then you get inflammation, and when you get inflammation, you get scarring, which we also call fibrosis. And we can try if you can also speak English, if you understand these mechanisms. What if you were in a drug company would you try to address? Where would you try to develop treatments? Anybody daring enough? Well, the first thing, and that's based on what we're doing right now, is to reduce the strain. If the fabric is not as tough, not as durable, try to put less stress on it, okay? And the stress on this fabric is the filtration, the volume of blood that's being filtered through, and the pressure in these little filters. So if you try to reduce the stress, you will put you put less strain on the fabric, and it can last longer. The second mechanism that's addressed with medications is to try to reduce the inflammation that happens when this fabric breaks down, and with that also to reduce the formation of scar tissue, the fibrosis. And the third and ideal mechanism, of course, is to try to correct the genetic mistake. There is one single variant in one of these genes, or maybe two of them. We have the tools, the gene editing as we call it, to correct these mistakes. The big problem that we have not solved yet is how do we bring these tools specifically to the kidney so that they can work and correct that mistake. Okay, now to the treatment options, and in black will be those that are already existent, and in red will be those that are new, either already in the clinic or in development. And so the standard treatment, and you've heard that also we talked before, of course, is the ACE inhibitors, angiotensin converting enzyme inhibitors, or angiotensin receptor blockers. These are the medications that reduce the pressure in these filters, and so there is less strain. And that has been initially tested in mouse models, and it works beautifully, but there's also clinical data from humans. So that is the established therapy that pretty much everybody with Alport syndrome gets if they have symptoms such as proteinuria. Then new treatment options is the addition of mineralocorticoid antagonists. So mineralocorticoids are hormones that also help to increase the blood volume and thereby also increase the pressure in these filters. There are some studies ongoing about that, but I don't think there is a final word about the efficacy out there yet. They are always used in combination with the standard therapy, with the ACE inhibitors or with the ARBs. And then there's other medications, other receptor blockers that also affect the pressure in these filters. And one of them is called sparsentan. There's also a trial out there. In the mice, again, it seems to work better than if you do the angiotensin receptor blocker alone, but how that translates into humans, we're still awaiting those data. And then The big new player in the game, of course, are the SGLT2 inhibitors, also called gliflozins, empagliflozin, dapagliflozin. They block a sugar transporter in the proximal tubule. And it was initially designed to treat diabetes. And it turns out to be the new wonder drug in nephrology that seems to make everything better quite dramatically. It's really astounding, the clinical data that are coming out there. And they have been tested also in Alport syndrome, and there also seems to be a clinical benefit. Again, they're given on top of the standard treatment of the ACE inhibitor. Then there was a lot of discussion about this drug called bardoxolone. This is now the second mechanism. First ones all were about reduction of stress. Now we're talking about reduction of inflammation and fibrosis. This was a very controversial drug. There was a trial in Alport syndrome that actually showed that the GFR, the volume of blood that's being filtered, sometimes we also just simply refer to it as kidney function, was better preserved after 2 years of treatment in those who received the drug compared to placebo. But the data also showed that this was at the expense of more protein in the urine, higher blood pressure, and this indicated that probably it was due to increased filtration of blood, hyperfiltration we also call it, which actually puts more stress on these filters. So that maybe for 2 years you get an initial benefit, but if you were to draw out the study over 10 or 20 years, you probably would see a negative effect of that. And this drug has also not been approved for the treatment in Alport syndrome. So there was a lot of discussion, a lot of hype about it in the beginning, but I don't think anybody is still proposing to use this drug. There is another drug that was also very effective in mice, and it addresses, again, the inflammation through these microRNAs, which is a complicated way of gene regulation in our genome. Beautiful data in mice showed a nice benefit, but the trial in humans, unfortunately, has not borne out any benefit. There is apparently a trial in China I've seen which uses hydroxychloroquine, which is a very old drug. It's a drug that's used in rheumatic disorders, so it's also an anti-inflammatory drug. And again, there is some efficacy shown here in IgA nephropathy, and this trial in Alport syndrome is ongoing, so we don't have any data there yet. Metformin, another very old drug, now being trialed in a number of completely different conditions. Again, has been shown some efficacy in mice, no human data yet. And then come the SGLT2 inhibitors again. So they not only seem to address the stress, they also seem to address the inflammation. How? We have absolutely no idea. How does blockade of a sugar transporter in the kidney reduce inflammation? But consistently across many disorders in the kidney, including Alport syndrome, we see less inflammation and less fibrosis when we use this drug. So that seems to work across two mechanisms, the reduction of stress and the reduction of inflammation and fibrosis. And then correcting the genetic mistake, the holy grail, of course, for the treatment of Alport syndrome. As I said, genetic gene therapy does not really exist for Alport syndrome yet, for no kidney condition yet, as far as I know. But some trials have been made here with this drug that is, aminoglycosides are antibiotics. But this is modified so that it doesn't have any antibiotic effect, but that it affects the reading of the gene. So in patients who have a premature stop codon, so where the genetic variant stops the reading of the gene, so that you have a shorter version of the gene. If you have this premature stop codon, this drug helps the cellular machinery to read through the stop codon and complete the entire construct of the gene. Now, obviously that means that this drug would only be suitable for patients with these very specific mutations. And that's a very small percentage. But these are typically also the most severe mutations, these nonsense mutations. So it could be a drug for those with the most severe form of Alport syndrome. There's been a clinical trial in 3 patients in London. The publication is hopefully coming out soon. They did not really show any benefit with regards to proteinuria, and that was the main outcome measure. Patients got treatment for 12 weeks with this drug, and then the proteinuria was assessed. But all patients had a biopsy before and after the treatment period. And that did show some benefits with regards to increased type 4 collagen expression in the kidney. And also with the better appearance of these filtration slits so that they came more into the normal range. So I can show this. No? Which one? Yeah. So here this would be the biopsy at baseline before the treatment, and in green you see the collagen type 4, and you see that in this particular patient, after the treatment there was a lot more expression of the collagen type 4, and this is about the appearance of these filtration slits, which improved in all of these patients. Okay, yeah, I talked about that, so I don't think I need to repeat that. So in conclusion, I think the good news really is there is a lot of interest of the pharmaceutical industry in trying to get new and better treatments out for Alport syndrome. Unfortunately, quite a number of these drugs that seem to work very well in the lab, or seem to work very well in mice, do not seem to work as well as we hope in humans. I think the most important new class of drugs that's coming on the market, and that will, I'm convinced, also be of clear benefit for all patients, is the SGLT2 inhibitors. That, again, as I said before, seems to work in most kidney disorders and already has been shown to work also in Alport syndrome. We don't have any pediatric data yet for the SGLT2 inhibitors, but the trial for that will start actually, I think, this month. So hopefully we will have those data soon as well. Yeah, and the gene therapy, unfortunately, is still somewhere in the more distant future. And with that, if you have any questions, I'll be happy to try to answer them.